We'll move on to the next talk. It's by Dr. Akash Tiwari. He is a consultant medical oncologist at Shalby Hospital, Indore. He'll be talking on the screening perspectives of lung cancer. What do you say?
Good evening, everyone. I hope I'm audible.
The yes, slides are visible. Sure. Yes.
So we today, in the era where in most conferences we discuss adjuvant targeted medicine, immunotherapy, or in our academic sessions where we discuss who would require adjuvant chemotherapy, radiation, not require therapy. The topic is interesting and it concerns primarily the community. So it is in screening perspectives in lung cancer, if it is the prime time currently or not. So why this talk of screening in lung cancer arises? And it comes from this startling data that only 14% of the patients that we see in our practice come with localized diseases. And lung cancer, despite of its reducing incidence, still continues to be one of the tumors with highest mortality rates, and hence we need to diagnose these patients at an earlier stage and treat them accordingly. So this has been an unmet need in oncology for a significantly long period of time. We see that over past few decades, the incidence in men has reduced startlingly, almost by 3.1%. Also has the mortality reduced, but it still remains, the age-adjusted mortality remains of around 20-25% in men. In women, even this decreased in incidence of lung cancer has not been so stark, though of course with improved treatments, the mortality has reduced. So we have a disease whose incidence is reducing, but the outcomes remain dismal. A disease which is primarily picked up in a higher stage disease. So we see in certain series that almost 65% of the patients are diagnosed in stage 4, or almost 1/3 of the patients are locally advanced, and only around 1% of the patients are diagnosed in early stage tumors. On the contrary, once we diagnose them in stage 1A, stage 2, the survivals ranges from between 60 to 92%, which is as good as the survivals in breast cancer that we get. So what do we want? We want to diagnose these patients earlier. That is, we want a stage migration for our patients. There are two main strategies that can be used for this. One is screening, which is of course the mainstay of the strategy. Other is the incidental pulmonary nodule strategy. So finding these incidentally found nodules and following them up to diagnose an early disease or to label them as benign. So in screening, there have been two main trials that have come up. One was the NLST trial, other was the Nelson trial. In both these trials, they had found out these high-risk populations, people with high smoking indices, people who had who were men who continued to smoke. And in this population, when we had done a low-dose CT and compared it to chest X-ray, we had seen that the mortality or the relative risk of mortality has come down by around 20%. So in the NLST trial, this criteria was based on the size, whereas in the Nelson trial, this was based on the volume of the disease. The second question in this screening comes out to be, though we know that there's significant data of screening the high-risk population, and as an individual, in individual internal medicine practice, we must offer it to our patients. Is a mass population-based screening possible in India? And there are a lot of limitations that come to us. So first is infrastructure. providing so many CT scan machines at every nook and corner of the country. The cost of such an intervention, depending who bears it, the government or the patients. Then the criteria of high risk is based on smoking index, but a lot of various forms of tobacco are calculated are consumed in our country. So what would be the equivalence? And then there are the routine issues that come with screening. So the motivation, chances of overdiagnosis, and a peculiar issue in our country that the chest infection and pulmonary tuberculosis rates are very common. So there'll be a lot of confusion in terms of what is a granuloma, what is a suspicious nodule. So one strategy is screening the high risk. The other strategy is incidentally detected pulmonary nodules and their follow-up. So we see in this beautiful graph that almost in a walk-in clinic where we are seeing only lung nodules, around 62%. So almost 2/3 of the patients that we see are actually incidentally diagnosed pulmonary nodules. Of course, not in our scenario, but a lot of Western countries. And there are only 15% that are symptomatic, 13% that are screening detected. So our focus on these incidentally detected pulmonary nodules should be stark. If we find these patients which are incidentally detected pulmonary nodules and we follow up them thoroughly, we see a stage migration. So in symptomatic presentation, almost 60-70% of the patients will be stage 3, stage 4. While if there's an incidental nodule program, the rate of stage 1 detection is increased to almost 54%. And this is something that can be implied in our practice, especially when we have seen that a lot of CT scans that we have done for COVID, they reported certain nodules. And some of these patients, when we have followed up, they have turned out to be CA lung in subsequent times. So a lot of oncologists have similar stories. So how do we otherwise move up in the lung cancer ladder? So where we focus currently as oncologists is optimal systemic therapy, correct diagnosis, surgical resection, radiation, what form of treatment we must select. There are two other points of ladder. The most important is tobacco control. If we are not controlling tobacco, the next step is high-risk population low-dose CT. We feel that the missing link here is the management of the incidental pulmonary nodule. So a CT that is done for an unrelated reason, a thoracic CT for a CT angio, a screening CT before a surgery in these things. If we detect an incidental nodule, depending upon its size, the age of the patient and the risk of the cancer, we must follow these patients regularly. So that is one important message that we must take from here. There are two main data of low-dose CT. One is of 30 pack years versus those in more than 50 years and 20 pack years. You know, as we reduce the threshold of our screening, the chances of picking up cancers increases, but so does the chances of picking up false positives. So how should we practice? Till such time that there is a universal lung screening protocol in India, which is unlikely to be given our current health scenario and lacunae at far more important places, we must offer low-dose CT to our high-risk population who come to our clinic and do an IPM detection as complementary strategy. With this, we require actually a collaboration with the pulmonary medicine team and the medicine specialists who get their CT done, and we have to educate them for follow-up. One important strategy that can come handy to us is artificial intelligence. So currently we see that there's a lot of push, a lot of publications coming in this sphere, a modality that will help our radiologists to diagnose doubtful IPNs and to follow them subsequently. A lot of time we feel that the time of AIs have not come, and probably we, without the help of technology, will keep seeing our patients as radiologists and medical oncologists. But remember, pre-2020 March, a lot of us also did not believe that we'll be doing these online meetings regularly and not meeting up over a drink in evening to discuss oncology. And we feel probably in the same spate, probably AIs would also change how we diagnose IPNs and follow them up. So how can we as oncologists support in early diagnosis of lung cancer? One is that we can create this awareness in general physicians and public that lung cancer as a disease, to diagnose them early, so that a lot of patients that we see who come as treated as tuberculosis get their biopsies done. We have to remove the stigma associated with the disease so that people come up with it. We have to collaborate with our physicians, pulmonologists, so that if they detect incidental nodules, we should do a thorough follow-up of it according to the existing guidelines. And we must show our community that lung cancer patients, if diagnosed early, survive. Even in metastatic disease, they have good outcomes, so that people continue to have positive outlook towards it. So of this question that is it prime time for lung cancer screening, we feel that lung cancer still, even with decreasing incidence, is a disease with high mortality. And if we do not intervene now, when would we do? And therefore, on individual case-to-case basis, as practice, we must offer low-dose CTs, and we must help our colleagues to or educate them how to follow up these incidental pulmonary nodules, such that we are able to diagnose lung cancers early. Thank you.
Thank you so much, sir, for that talk.